So much of public education is funded by property taxes. And the U.S. promises equal education for all, and then we overlay on that property taxes, ensuring that people in low-income neighborhoods have less funding for schools. It's an insane system. We can change them. We just have to make different decisions. And we can't make those different decisions unless we have the education. And that is what you're providing.
Country is really based on that idea of equal access to opportunity. America's educational system is an aristocracy posing as a meritocracy. Structural racism, again, the data is, overwhelming. When I was a teacher and we looked at structural racism, the question of what to do about it. Now, that is an opinion question. That is a policy question. There is no right or wrong.
I'm Zoe Weil, and this is Solutionary Voices, a podcast brought to you by the Institute for Humane Education, an organization helping to build a more just, compassionate, and healthy world for all people, animals, and the ecosystems that sustain life. On this podcast, we bring together guests on the forefront of addressing local and global challenges and whose lives, ideas, and actions we hope will inspire you to find your own solutionary path. Today I'm speaking with Ayo Magwood, founder of Uprooting Inequity. Ayo specializes in evidence-based solutionary training to understand and remediate structural racism. She is dedicated to fostering cooperation across differences to bring about equal opportunity for all. Her superpower is her ability to synthesize a wide range of research, data, primary sources, and abstract concepts and weave them into what I consider among the most effective educational initiatives and presentations to create systemic change around structural racism. As Ayo says, none of us is to blame for the past, but we're all collectively responsible for the future. I'm thrilled to have this brilliant solutionary on the podcast. Welcome, Ayo.
That's so generous of you. And I am so happy to be in conversation with you again. And I'm very grateful and appreciative that you've invited me on this podcast.
I can't wait for people to learn from you. So always the first question on the podcast is, what problem are you working to solve?
I'm fascinated and obsessed with remediating racial and income disparities. I've done it in general. I've looked at education. I'm going to look at housing next. But right now, I'm focused primarily on healthcare because there's huge disparities in access to health and in health outcomes. And I find that healthcare institutions and organizations are very incentivized and eager to work on it. So that provides an opportunity to work on really concrete and measurable outcomes in reducing disparities, which is exciting as a solutionary.
I love that you use the term solutionary to describe your work. And I believe that your work exemplifies solutionary thinking and action. And by that, I mean you help people uncover the root and systemic causes of persistent inequity and look for targeted and effective strategies to implement system change. And before we dive into your solutionary approach to uprooting inequity in the healthcare system, I think it would be helpful for some of our listeners to have you describe the difference between racism and structural racism.
So racism is a very general term that encompasses a lot of things. On one hand, I have a model. The model is called Structural Racism Pathways to Health Disparities. And that breaks down structural racism into its three components. It operationalizes it because, again, the more concrete we can get, the better we can address it. So the three components are RIP, rest in peace. The R is racism, which is what popularly people refer to as racial bias, discrimination, and stigma. So that is more on the individual or personal level. And then the second component is income. it refers to racial income and wealth disparities and education. And then the third, or P, is place, geographical disparities in access to resources and opportunities. Most low-income African Americans are segregated in neighborhoods that are racially and income segregated, that have very little access to resources and opportunities such as quality schools. So that sort of answers your question. The structural racism encompasses all of that. And in fact, the more of the emphasis is on place. For example, with racial disparities in health and education, the biggest component is actually that place. I mean, they all overlap and intersect and exacerbate each other, but place is a huge ignored aspect of structural racism.
As you and I both know, there are people who insist that we don't have a structural racism problem. And when you hear people say that, how do you respond?
That's primarily a popular misconception. But in research, if we look at academics, the research is absolutely overwhelming and it's universal. I don't think there's a single article, any research that suggests that there doesn't exist. In fact, it's more that how much, and where and when and how. So the evidence is pretty overwhelming. So, for example, areas that have been, you can look at maps. I draw up these maps with circles, and you can look at a geographic area, for example. I put a ring around the area, the old redlining maps from 1939 that were racially segregated and that were systematically denied wealth. And then if you overlay a map from today of so-called exclusionary zoning, which means areas that are zoned for detached single-family housing only. When racial zoning was outlawed, the actual U.S. government went around telling people, the local areas, that you can actually just replace where it says white only on the zoning maps. All you have to do is replace that with detached single-family home only, and then that, in essence, keeps your area segregated because African Americans and Latinos are generally low income. So if you overlay exclusionary zoning maps on top of the old redlining maps, they align perfectly. And then if you overlay on top of that maps of health outcomes, for example, diabetes or asthma, then they match up exactly too. So that is a visual example of how these old historical policies are still affecting people today, partly because they are reinforced and reproduced by modern day policies that are on the surface, they are race blind, but they use income, for example, or place, geography, as a proxy for race. And so they reinforce and reproduce these old historical policies that still have an effect today.
When I first learned from you that the 1944 GI Bill exacerbated racial inequities, that was such a wake-up call for me. It was not something I knew. And I think most people don't know that. I think that while what you said about, you're not going to find articles that argue that structural racism isn't real, but you find people who think, oh, that's in the past. We've solved that problem. And when you describe what you just described about redlined areas and zoning, I think people, it's like a light bulb goes off in their head. They go, oh, I get it. This is still going on today. Can you talk about that GI Bill and how it exacerbated racial disparities?
So the GI Bill was originally designed for all veterans. And in fact, the people who designed it thought this is a fantastic opportunity to help reduce the racial gap and to help African Americans catch up. But the Southern congressman refused to sign the bill until they added that it could be locally implemented. And of course, the very obvious intent was to deny GI bills to African Americans. And that's exactly what they did. They used lots of various different methods to deny those benefits to African Americans. In the North, in some areas, African Americans were able to access them. but most African Americans at the time were in the South. So the GI Bill benefits went primarily to white veterans. In addition, even when African Americans could access those benefits, they couldn't spend them on housing in white areas because, of course, those areas were white only. And it was similar with education. So again, African Americans did not receive educational benefits at the same rate, but in addition, they had nowhere to spend them because schools were segregated, and there were very few vocational schools or schools of higher learning that accepted African Americans. One historian, Ira Katznelson, actually wrote, "There was no greater instrument for widening an already huge racial gap in post-war America than the GI Bill." He wrote that in his book, When Affirmative Action Was White, written in 2005. So that actually caused a vast increase in racial disparities in housing, wealth, and education.
That's really helpful. So when I first met you and learned about your work, it was in the context of teaching about these issues in usually school-based settings. And now we've had this huge backlash to teaching about racial injustice and anything that sounds like DEI. And you're now focused on healthcare disparities. I would love to hear about your work in the healthcare arena. And when you're done talking about that, I would also love to hear if you have any solutionary ideas of how we make sure that young people still learn about what you're teaching.
So as you mentioned, the demand for education about racism has dried up in not just in schools and education circles, but also more general audiences, such as community groups, because of the current climate. I think partly because education on racism to them is often more theoretical. So it's a nice thing to know, but sort of more for their personal edification, and they might try to implement it on the individual level, but it usually ends at that. In the healthcare industry, this education is vital. They don't see it as general education, but as tools, solutions, strategies to help them address very, very real and consequential healthcare disparities that affect of course, they care about health disparities in general. Providers care very, very much about health and well-being, but also on the institutional level, they care deeply because it affects their bottom line, right? It costs them a lot of, health disparities cost them a lot of money and also affect their hospital outcome metrics, their reputations, in addition to provider burnout, which is a huge problem. So there's tons of incentive on the both the individual and the organizational, institutional level to address these health disparities. So learning about this is not just theoretical, nice to know, makes me a good ally to learn about. It's like, okay, nuts and bolts, let's get down to business. We want to find out who, what, when, and where these health disparities are occurring in our hospital catchment area. We want to know the root causes so we can sit down with community-based organizations in that area and reduce, for example, asthma disparities by 10% in our catchment area. They are more immune to the chatter about DEI because they see how it actually works, that what it actually does, that this is not about shaming and blaming, that we're not sitting around talking about our feelings and our attitudes. This is about how are we going to lower these health disparities in our area. So that also makes it very meaningful and satisfying for me because I get to see, this history and these ideas. I get to work with people who are solutionaries, right? Who are working on very concrete evidence-based solutions. So it's a win-win.
So some of what you've described sort of harkens to what you've talked about in terms of racial bias training as ineffective, and what we really need to do is address biased behavior. Can you break that down a little bit for the audience?
So first of all, racial bias, like I said, is only one part of the picture. We tend to focus only on that. Oftentimes, like I said, that those other two components, income and place, again, they're all overlapping, are much more consequential. So that's first of all. But second of all, the research has shown, and remember I said the research shows that structural racism, that's, overwhelming. Well, the research is also overwhelming that racial bias training does not work. It's completely ineffective. And in fact, it actually is often results in the opposite, right? It often increases opposition to working on these kinds of things because it's almost impossible to change people's attitudes and thoughts. So the research shows that individuals who are voluntarily working on their own biases, so if you choose to voluntarily work over the lifetime, it can be effective. However, outside of those circumstances, it is miserably ineffective because the biases are basically evolutionary, right? In-group biases, meaning both out-group prejudice to out-groups, and in-group favoritism, which is just as, if not more strong. In fact, research shows that discrimination and double standards have more to do with in-group favoritism than they do with out-group bias. But anyhow, those are basically evolutionary mechanisms that we developed because, back in caveman days, those who had stronger biases were better able to cooperate with their in-group members and fight against the common threats and outgroups, and thus survive and pass on their genes, right? Natural selection, right? So that is not going to work. But as an institution and organization, what you can do is disincentivize and plan for the impacts of that biased thought, right? Biased behavior, right? You can and should do things to prevent biased behavior from affecting your company, affecting your employees, and affecting your clients or families or customers, right? And they call that behavioral design, which means setting up policies and practices to minimize or disincentivize biased behavior. For example, in the healthcare setting, there are algorithms that you can use. They're imperfect, and lots of times the design is affected by bias, but there is promise in working on those. Or, for example, there's a big problem. Oftentimes, providers don't do additional tests or don't ask additional questions, and thus do not diagnose, for example, asthma in African Americans and Latinos or low-income people in general. So what you do is you have a computerized system where it sort of walks you through all the questions. Did you do this? Did you do this? Did you do this? And the provider can just click through them, but it just gives them a second to, it's a tiny prompt, and it forces them to say, oh, to think through those steps they would normally do. We do address that, those solutions addressing a biased behavior on the healthcare level, but we're also focused on the effects of income and place, and all overlapping.
So can you tell us some of the outcomes that you're seeing from doing this work with healthcare providers and institutions?
So I'm working primarily with Wake Med, health and healthcare institution in Wake County, North Carolina, in the Raleigh area. I worked with them to develop this curriculum. So I was working with providers and reading tens and thousands of medical journal articles. What I do is I break down structural racism into its three components: RIP, racism, income, place. And then I have a set of 5 pathways through which they affect access to what is known in the healthcare industry as the social determinants of health, or the social drivers of health. For example, access to healthcare, education, economic stability. And then those get traced on that pathway to biological responses of the body, and then behavioral responses to those biological responses. And then from there, we trace that to the actual illnesses and health. And then using that in addition to maps, I've developed GIS maps, quantitative maps of the county, Wake County, and I have little markers indicating there are 3 hospitals in the area. And then looking at the maps, there's one map that where we can see the income levels, right? Socioeconomic levels. And then there's another map where we can see asthma levels, and another one where you can see diabetes rates, et cetera. So healthcare teams that are going through the curriculum. The curriculum is about 12 sessions. So first, after the introduction, I go into the history. From that history, then I bring it forward. We look at the modern day policies, such as exclusionary zoning, and then we look at access to health and stores and food and transportation, et cetera, in those areas. And then they use a quality improvement process. They have this plan where they identify a problem, they identify a very specific measurable goal, and then they implement something, and then they track it. They measure progress to try to achieve that goal and improve that outcome. The teams are working with the information, that knowledge that I've provided them. They're working with those geographical maps. They're working with data from the hospital that the hospital has started to collect thanks to my training. They realized they were collecting a lot of information about the clients, but for example, they realized they weren't collecting information on place where the patients were living. So using that data, they sit down with their healthcare clients or their families, and together they identify structural root causes of the problem and then identify evidence-based solutions that address that specific root cause. And sometimes that can be very, very simple. Let's say the asthma clinics are in areas that you need to take 3 buses to get to, right? So it may be as simple as providing vouchers so that clients can get to their appointments in a timely manner, because parents are busy sometimes with 2 or 3 jobs, so that voucher can make the difference whether they're coming to their appointments regularly or not. It also just more generally helps because then providers have better insight into some of the challenges that their patients face. It's very easy to judge what we believe is poor behavior on the part of the clients. Oh, they're sick. They're not getting better because they're non-compliant. Well, now they realize non-compliance means they can't get to the appointment, right? Or they're saying, oh, well, they're not taking their medication. It turns out they can't afford it, right? Or they can't get to the pharmacy. Oh, they're, eating a lot and they're not exercising. They don't have access to healthy foods or places that they can exercise, right? So indirectly, it has a huge effect as well. Not only are you addressing that bottleneck, that structural bottleneck, but you're providing providers with some insight into the challenges their patients face, which reduces bias indirectly, right? Even though you didn't directly address that, it's helping to reduce those biases and allowing them to be more compassionate, and also allowing them to guide their questions, right? Usually, and guide their guidance, right? Instead of just saying, exercise more, lose some weight, you're better able to guide your questions and to point them to resources that they actually need. We still don't have actual measurable outcomes yet because we're still starting. We're still in the first year, but it is looking good and the providers are very excited. Like I said, it's concrete, very actionable and solutionary, right? Everything that mentions the word race gets cast in the same bucket, right? Again, we're getting away from that theoretical stuff and getting our hands dirty and looking at, environmental, climate, racial, income issues in our specific area.
Thank you for all of that. So the first thing that came to mind as you were describing the process that you are using with these healthcare professionals is every step of it is like the solutionary framework that we teach at the Institute for Humane Education. Identify the problem. Make sure you have a problem statement that you can evaluate, like whether you're succeeding or not. Implement your solution and evaluate it and adjust. Like it's beautifully solutionary in every way. And I would say that, while it pains me that you're not getting invitations to do this work with students directly in this particular climate, I do want to think about solutionary ways to make that happen. I'm aware as you're speaking that the solutionary framework, when we are training teachers to bring the solutionary framework to students, they choose the problem they want to address, and many of them care about social justice issues. And some of them, in the sort of political climate that we're living in, you can imagine that there are some kids who have learned about issues from their parents who have one perspective, and other kids who are learning from their parents who have another. And I'll give you just one example. There was a boy who, when invited to address a problem that he was concerned about, he wanted to address the problem of immigrants taking jobs away from people where he lived. And the teacher trusted the process. So the next thing he had to do was he had to investigate the problem. And he quickly discovered it wasn't a problem. Immigrants weren't taking jobs away from people where he lived. In fact, there weren't enough people for the jobs that they had in their community. And so he had to say to the class, I thought this was a problem. It's not a problem. I need to address a different problem. That also happened with another boy who wanted to address the problem of Second Amendment rights being eroded. He was scared that the government was going to come and take away his family's guns. And the teacher trusted the process. The students started researching and realized nobody's coming to take away their guns. And in fact, gun violence is a really big problem. So the process itself worked. That when you're really exploring these issues and you're getting accurate data, then the possibility arises that you are no longer thinking in these sort of either or terms that our culture, whether it's media or politics, is framing. You're actually discovering the underlying problems and you're addressing them. And I feel like that's exactly what you're doing. I hope listeners who, whether they're in the healthcare profession or not, they're going to share this episode with their healthcare providers and local hospitals, because we need much more of this. And who, like you were saying, this is a win-win-win. Who doesn't want these positive outcomes? Everybody wants them.
No, I love that. And hard agree. And I'm actually, as you know, a former teacher. And of course, that is also, just plain good pedagogy, right? You don't tell your students what to think, right? You help them, like you said, identify. And also that's science. That's what science is about. That's what, and history and, academics is about. Learning is about. You set up a hypothesis, right? And then you go and do the research, and then you find out, you look at the data, and the answer may not be what you thought it was, right? Or it's much more nuanced, and there's no, it's not either or, right? It's somewhere in between or in left field, right? So that is also just good education, right? Good pedagogy. And I used to teach like that. And I just love it.
So one of the things that I've also heard you talk about is the need to distinguish between empirical and policy issues on race. Can you break that down for the audience?
Empirical issues are those that can be discovered through science, right? Through data. They either have a right or wrong answer, right? Whereas empirical policy issues are those that it's based on your opinion, what to do about those problems. So again, structural racism, the data is, overwhelming. It just exists. There's just no wiggle room there. However, when I was a teacher and we looked at structural racism, the question of what to do about it. Now that is an opinion question. That is a policy question. There is no right or wrong. Of course, even people within the same ideological party may differ significantly on that answer, right? So that's how I dealt with the teaching about race and racism when I was in the U.S. history classroom. We distinguished between those two. So, for example, at the time, affirmative action was a big issue, right? So we could look and, racial disparities in access to education, not education outcomes. We're talking about access to quality education. We looked at those. The data is very damning, right? Also, there's a huge differences in advantages or benefits, preferential treatment. There's lots of emphasis, lots of attention on affirmative action, which is defined as preferences based on race. So we looked at all the data, right? But then when we had deliberations, I don't believe in debates, we have deliberations when you're trying to understand and deepen your understanding of an issue, but you still start out with opinions. Students could take any position they want. They could be dead set against affirmative action. That's great, doesn't matter, but as long as you're basing them on fact. The problem is when people say that structural racism doesn't exist, therefore racial disparities are due to differences in culture and effort, right? Because that's what they conclude, right? Once you sort of get that out of the picture, once you see that there's very, very, very real, concrete, measurable, tons of data behind the reasons behind those disparities that have nothing to do with effort and culture. Once the students have laid those out on the table, then you basically take racism out of the classroom. You set up sort of guardrails, right? Because nobody's going to say that. No one's going to say, we don't need affirmative action because Black students aren't studying enough, right? You could have other reasons, right? You can say, yes, there's differences in access to education. I don't believe in affirmative action, so we should instead fund schools more equally, right? So that everybody has equal access to education. For example, right? That could be your solution. But you could be dead set against affirmative action. That's fine, as long as someone's not going to say it's because Black people are inferior, right? And the other guardrail is set up is that somebody who's conservative who wants to say they're dead set against affirmative action because they are against the government intervention, they're not going to get called a racist. See, because their reasons are based on actual fact and not racial stereotypes. So it was perfect. I would set it up in the very beginning before we had our unit on. We looked at the GI Bill and stuff like that. So we were looking at the 50s, and there's tons of race-related aspects. So that was the very first day. I would very openly set it up. I was like, okay, these are empirical issues. These are policy issues. Structural racism. You're going to spend weeks looking at that data and that history. At the end, we're going to have a deliberation on policies that. You can say whatever you want. I am not going to tell you what policy to address. And you could hear, everybody was like quiet for you could hear the cog, the wheels of chugga, 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 chugga. And they're like, wait, that, what? Oh my God, that works. Yes, that works. Oh, that's perfect. and it worked wonderfully. We could have deep, meaningful, tough conversations about race and racism across the ideological difference, across racial and ethnic differences. I also paired that with something that I call perspectives training, but orientation. So actually the day before that, I would do this exercise. I essentially made an interactive exercise on the blind man on the elephant metaphor. So I found this old bear sculpture that I found in the corners of the art room. And then I hid it in behind my desk, and I blindfolded 3 volunteers, and I put a different part of the bear sculpture in each of the hands and asked them to describe the shape. And then I took it away and then said, okay, so what is this object? And of course, they disagree completely. I took out the bear and I said, what happened? What happened? And then also I put up a map. I was in DC. So I put up a map of DC showing, racial segregation in DC, and another one showing ideological segregation, and the third one, income segregation, right? So I was like, what do those maps have to do with this bear? And I also shared, the anecdote, the story, the allegory of the blind man and the elephant. So they sat there in their groups looking at the maps and talking, and then each year, same thing happened. After about 5 minutes, one of the students would yell out, "Oh my God, we're not just touching different parts of the elephant, we're living on different parts of the elephant." And so that is a very, strong realization for them. So, and I put up that picture of the elephant on the wall, and they would refer to it throughout the entire year. Like when a student would say something biased or from a single perspective, then they would say, "Remember the bear," or instead of "remember the elephant," or one of the two, they would say. So that also helped. So the idea was that when you're living on different parts of the elephant, not only do you have a different perspective, right, on an opinion, right, but also you have different lived experience with empirical issues, right? So it's both those things. And in fact, one of the reasons why we have different opinions or perspectives on policy issues is because our lived experience is so segregated. So economists call it hyper-segregation. The United States is hyper-segregated, both economically and racially, and it's getting worse and instead of better. It got better for a little bit, and then the 80s, it switched back, and it's getting more segregated. So we don't see all of America. We only see, if we're wealthy and white, we see mostly wealthy and white. If we're low income and Black and Latino, we mostly see that world. So it is very eye-opening for the students to see national level data, averages. They're like, yeah, that looks nothing like, that's not true. That I have never seen that. And then another kid in the classroom be like, "You're on the ear of the elephant. That's why you never come to my neighborhood." So it's that looking at that. So that elephant thing was combined with the empirical versus policy issue thing was essential in allowing us to have very productive, open, free speech, civic conversations, discussions, tough discussions in the classroom that did not devolve to racism.
There's so much in what you just shared. I have to say how delighted I am to hear you talk about deliberation instead of debate. I am also not a fan of the debate process and have written about that in my books and in essays. I think that it reinforces this thinking, where this either or polarized thinking and competitive thinking, as opposed to everything you just described. So I really appreciate that. I also think that I want to just say another word about the segregation and the ongoing structural problems. So much of public education is funded by property taxes. And the U.S. promises equal education for all, and then we overlay on that property taxes, ensuring that people in low-income neighborhoods have less funding for schools. I mean, it's an insane system. There are all of these structures that are inequitable and unjust and creating segregation and creating winners and losers. And we can change them. We just have to make different decisions. And we can't make those different decisions unless we have the education. And that is what you're providing. So I'm really grateful to you. And I have one last question for you. Unless there's anything that you want to say that you haven't said that you want the audience to know.
I do want to follow up on that education piece, and because definitely education is ground zero, right? There are vast disparities in access to education. Again, we're not talking about outcomes, but about access to education. The economist Anthony Carnevale wrote after his investigative report, "America's educational system is an aristocracy posing as a meritocracy." Right. So, they're just layers and layers. So the differences in school funding definitely is a big piece. I would love to be able to work on that. So hopefully, there's an opening for that in the future, because that's definitely ground zero, The second thing is, speaking of education and access, I think that's what we have to focus on is access to opportunity, right? Our country is really based on that idea of equal access to opportunity. And so a lot of our discussions, in fact, are based on that assumption. Well, everybody has equal access to opportunity. So if outcomes are unequal, that must mean, people are not working. Some people are not working hard enough. But that assumption of access to opportunity does not, if you just start looking at digging for 5 minutes, that falls apart really quick. We have vast inequities in access to opportunity, access to education, access to health, access to employment. So I think that's something we can all really rally around, right? If I was going to take anything away from this podcast, it's, no matter what area it is, what field it is, we should be focused on in realizing that ideal of equal access to opportunity.
That is a beautiful way to wrap up and lead me into my final question for you, which is, what would you like your epitaph to be?
Solutionary. Like Zoe.
Ayo, thank you so much for all of your work, for your really insightful way of bringing so much clarity around these issues to people. And I just hope lots of people will reach out to you at Uprooting Inequity and avail themselves of your offerings.
Thank you so much. I'm very appreciative.
Thank you so much for tuning in to this episode of Solutionary Voices. I hope you enjoyed it and that you will share it with others, particularly healthcare providers and educators who can learn from Ayo's work at Uprooting Inequity. And please do visit the show notes for more information on Ayo and her work. And if you would like to become a solutionary yourself, I invite you to read my book, The Solutionary Way. Please do subscribe and share and review the program. Thank you so much.